What I'd like to do is welcome Dr. Ken Shulman. Dr. Shulman is a world-renowned expert in testamentary capacity. He's a professor at the University of Toronto, practitioner at Sunnybrook, and really we're so fortunate to have him. And normally we would sort of play off the cuff, and I think that's what we're going to do a little bit, Dr. Shulman. But the things that I thought we might cover is sort of the limits and the role of a medical expert as on capacity issues, contemporaneous and retrospective assessments, how complexity and vulnerability can affect capacity and undue influence, and dealing with cognitive screening tests, and then lucid intervals. We may not cover everything, but I've got some slides that I can pull up, Dr. Shulman, as you see fit, and we can go from there. How's that sound?
Sounds good. So we've got 30 minutes, which is that right?
Yep.
So it's time. Time is an issue. Do we want to leave some time for questions, or are people going to ask in chat? How's that going to work?
Yep. I'm going to close my door, and yeah, we'll leave time for questions. Why don't we? Yeah. So just.
I'll try to be very brief in terms of the issues, and then leave some time for some interaction, and we'll get to that Montreal test as well.
Great.
So do you want me to address some of these issues first, and
Sure.
Then we can take it from there?
Why don't we talk about that? The role, what you can do and what you can't do as an expert.
Okay, so the role of the medical expert needs to be well defined. It's a very limited role in many respects, because when we're talking about the question of capacity, I guess today we're talking about specifically testamentary capacity, but when you're talking about any capacity, you're talking about a mental function, right, and a brain function potentially. So the issue of capacity is ultimately a legal determination, but it's really invites a medical legal collaboration. So the courts, lawyers, and the courts particularly will need from time to time some assistance in understanding the underlying mental and cognitive function of an individual where capacity is in question. So to be clear, in a will challenge, for example, the medical expert, although I'm often asked the same question as the trier of fact, Dr. Shulman, did this person have testamentary capacity? What I'm being asked is really from a clinical perspective. So we be clear that my perspective is clinical only. And my role, to help the courts make the legal determination, is to help the courts understand the nature and the severity of any mental or cognitive disorder that may be evident. And I can do that either contemporaneously, we can talk a little bit about that, by examining an individual, or in the case of a person who's deceased where there's a challenge after the fact, doing a retrospective assessment, usually of the medical record. So what my role, or what I think the role of any medical expert is, to help the court. Is there evidence for a mental disorder, for cognitive disorder? How severe is it? And how does it impact on the specific test? And in this case, testamentary capacity, as I think pretty much everybody would be aware, is really determined by the long-standing traditional Banks and Goodfellow test, and we can talk about those criteria. But that's really, I think, the role of the medical expert. Is there a mental illness? Is this person suffering from Alzheimer's disease? How severe is it? And how might it impact on the specific criteria?
Dr. Shulman, so yeah. you get involved potentially at two different stages, right? So the first stage that a medical expert could be involved in this issue would be a contemporaneous assessment. So we're often confronted with a client who may have some cognitive impairment, that at least we think there might be some cognitive impairment. And we are often, it's suggested to us that we should involve an expert like yourself at that stage. Can you take us through sort of what you would do at that stage, what you would need from us for a contemporaneous assessment?
Right. So the contemporaneous assessment, let's just be clear, is probably the gold standard generally for a capacity assessment. When retrospective assessments have their limitations. They actually have some advantages in some ways because you can follow a longitudinal course. We can get into that if you want. But really, the best test, the best way of examining somebody is contemporaneously, where you have an opportunity to probe the individual. And so, again, if we want to stick to testamentary capacity, um, what I would need from a lawyer who is asking for a contemporaneous assessment would be a summary of the relevant background. What facts should I assume about the case and the background case? And then specifically the request for a contemporaneous testamentary capacity assessment. But what the main function that I have is then to go through the Banks and Goodfellow test criteria and have an opportunity to probe, and does that individual understand the test? Now, what Jordy has just put up there, I've got to update that slide is outdated. It should be to 2021. So the 150th anniversary of Banks and Goodfellow was last year, but these are the traditional ones. We've tweaked it a little. This is from a paper that we wrote for the Canadian Bar Review. But I'd bring your attention to, capable of making a will, of understanding the nature of a will and its effect. That's pretty basic, and you'd have to be very impaired not to know that. So I think a lawyer would be able to determine that. The nature and extent of property is always an issue, and we've added that little phrase, relevant to the disposition. So I think it's generally agreed that individuals don't have to know chapter and verse of all the details, especially if it's a complex estate or corporations and multiple properties involved. But they do need to understand the nature and extent of property that's relevant to the disposition. If they're leaving a house that's worth a few $1,000,000 to one child and $100,000 cash benefit to another child, they need to understand that kind of difference. The issue number 3 is conflict and complexity. Now we don't have a lot of time today, but Jordy's quick on the draw here. This is the paradigm that I use to describe the role that complexity or conflict has. So very often the request is being made in an atmosphere where there's a conflict in the family, where the testator or testatrix is choosing to eliminate one of the children for whatever reason. And it's usually related to conflict or a complex family situation. And as you can see from this paradigm, I've put the x-axis is the degree of complexity going left to right. So from left to simple to a more complicated situation. And on the y-axis vertical, you have a shift in capacity from a high cognitive function to low cognitive function. So basically what this shows is if you're in the middle and you're moderately impaired, at a certain point, if things get too complicated and the conflict gets too complicated, you are going to, as you move to the right, cross into the incapable arena. And that is that you will lose the ability to sort out competing claims, one child saying this, another child saying that. So that's a paradigm for the role that complexity and conflict have on the shifting threshold for testamentary capacity. And then just to go to number 4, that to me is really the essence of what any lawyer, where there's any question about capacity, and certainly what I would do, is probe the individual's ability to provide a clear and a consistent rationale for why they're making the choices they're making. If they're eliminating one child and giving everything to another child, or decreasing to one child, they simply have to be able to explain in a clear, rational, and consistent way why they're doing this. And I think if they can do that, most often, 99% of the times, they are capable. Now, the final point, and this is where the Banks and Goodfellow originally was focused on this issue of a mental disorder or a delusion that influences the distribution. And this is where you may want to get a psychiatrist involved. If you're not sure, for example, they may be cutting out a child because they believe that the child, one of the children, is stealing from them. That's a common delusion in the early stages of dementia and Alzheimer's disease. If it's a delusion and if it's actually influencing the distribution, then according to the Banks and Goodfellow test, they are not capable. Conversely, somebody can have Alzheimer's disease or have a serious mental illness, as was the case in the John Banks case of the Banks and Goodfellow. He was mentally ill, but his mental illness didn't actually influence the distribution in his estate or his understanding and appreciation about his estate or what he wanted to do. So he was considered capable. On the other hand, somebody who believes that usually a daughter-in-law is involved, is stealing from them, or a son-in-law, and they cut them out on that basis, then they would not be capable. So I think that may be where the role that a psychiatrist or an expert could play is determine, is this person suffering from a dementia, and especially if it's in the early stages, and are their beliefs, in fact, delusions, and therefore not capable. So that's the kind of thing that an expert, I think, can help with, probing and determining whether a mental illness is present and whether it's influencing the distribution. And as a lawyer, if you're not sure, that could be a time to request a contemporaneous assessment. I'll say one final thing about contemporaneous assessments. The courts put tremendous weight on contemporaneous assessments. If you have a contemporaneous assessment that's well documented, and even if it's not well documented, the courts are inclined to put more weight on that than an assessment that was retrospective after the fact. Now, sometimes the courts are off on that, because sometimes there are times when a retrospective assessment is actually puts a clearer light on a person's capacity at a point in time. But the reality is that contemporaneous assessments carry a lot of weight, and a documented contemporaneous assessment is almost impossible to overturn retrospectively.
So, Dr. Shulman, at what point in the, I'm meeting with a client and I've got some, I'm not loving this in my interaction with them. There's some things that the client can't remember all the names and going to do something that seems a little bit untoward. At what point do I get you involved, or one of your colleagues? Do I draft the will first and then send them to you? Like, how does that work?
Well, I think there's probably a lot of flexibility in that situation. Ideally, from my point of view, I think a medical expert would be well served to have a draft of the will, or at least an outline of what is being proposed, the main features. The reason is that way you can probe those wishes, say, well, why are you doing this? What about this? You need to have something to probe. I don't think you can do a testamentary capacity assessment without something substantive to be probing, unless somebody is severely impaired, and then it's obvious, but then you probably don't need an expert to tell you that. Let's not forget that lawyers really are still in a position to make a determination about capacity. There's a presumption of capacity, of course, in law. Person is presumed capable unless there's reason to be concerned or to be suspicious about the circumstances. But yeah, it would help to have a draft or an outline of the proposal. And it's at that point that, fairly soon, an expert should be doing the assessment in time to the proposed execution of the will.
And that's kind of the problem, I guess, with these reports from family physicians. John is capable of making financial decisions. Without the context of, well, maybe you could speak to that those kinds of, I don't know if they're assessments or what they are exactly, right. Opinions.
Okay, that's a very good point. And I think lawyers should be very much aware of this. Sometimes the simplest thing is to go to the testator's family doctor. If you're concerned, and I've seen many lawyers do this, they will get in touch or write to the family doctor and say, can you give me an opinion about this person's testamentary capacity? Now, the reality is, You have to realize this because it's an issue later on. If there is a subsequent challenge to a will, and all you have is a family doctor's, you know, two-line letter that says, this person is capable of making decisions. I know this person well. They can make rational decisions about their finances or about any legal decisions. That is going to be very vulnerable to attack retrospectively because most family docs don't appreciate the nature of capacity. Doctors are not well trained in capacity assessment. And in particular, testamentary capacity, you need to know what the test is. Most doctors have never heard of Banks and Goodfellow. So if they tell you they can make legal decisions, a blanket statement like that is not of great value. And really what you need from a family doctor, if you want to get anything, is their report of, are there any medical conditions that might affect a person's capacity? They're the doctors in a good position to tell you the history. Have they had a stroke? Have they been diagnosed with Alzheimer's disease? That's the kind of thing a family doc can do. But I think asking a family doc to do a capacity assessment when they're not trained, and we're trying to change that in terms of medical education, but that's a very important point. And too many of these one-line letters are problematic after the fact.
Which brings us to this idea, which is now I didn't get an assessment and now somebody's challenging the will that I drew for this person. And as litigators, they're going to come to you and say, Dr. Shulman, can you give me a retrospective assessment? Take us through that and what that is about.
Okay, so very briefly, it's retrospective. Some people call it retroactive, which is incorrect. You're not changing anything. You're looking back, spective, you're looking back. So it's a retrospective assessment. And again, the role of the medical expert in these circumstances is really, as I said earlier, to identify the nature and severity of any mental or cognitive disorders and determine whether they have had any impact on the specific test in question, in this case, Banks and Goodfellow. The kind of thing, you can see here from the slide, the kind of thing that one reviews are affidavits, statements of claim, statements of defense. That's really to get the background context. And an expert needs to be clear what assumption they're making about the background facts, because ultimately it's they're in every dispute. There are different versions of the facts and what transpired. And a medical expert has to be careful not to be the one trying to determine who's right and who's wrong in terms of the facts. The role of the medical expert is really primarily to review those medical records and look for evidence of a mental cognitive disorder, look for those cognitive screening tests. We can talk about that in the few minutes we have. What do they tell you? What do the scores tell you? How do you interpret them? The one thing that I do find very valuable, other than the background facts, is the drafting solicitor's notes. And this is where it's important for lawyers to document very clearly, particularly the rationale that the testator has had for making a distribution, especially if it's not an equal distribution. Anything that's not equal is going to be vulnerable to challenge. So the drafting solicitor's notes, to me, are actually helpful. But most important, I need to have available all the medical records, usually going back at least 5 years prior to the execution of the will, so I get a pattern, and even medical records subsequent to the execution of the will, so that again, I can determine if it was questionable whether they were in the early stages of dementia and that their suspiciousness towards some relative may have been delusional. That is much clearer when I know that they went on to develop a full-blown dementia. If they didn't, that has a different implication. So these are the essential approaches to a retrospective assessment.
So many of us are familiar with screening assessments where people are done routinely. Even the family doctors will do an assessment using standardized tests, and we can talk a little bit about that. Maybe mention the two big ones that we see, and then what they are and what they're not.
Okay, so again, in order to leave a little time for some questions, I'll just be very brief about this. But this is often the case. People see scores of various cognitive screening tests. The two most common that you'll see in the medical records are the mini mental state examination, the MMSE, which used to be the most widely prevalent. It's a score out of 30. It involves, as you see, orientation to time and place. There's a memory, short-term memory test, concentration, language, and there's a intersecting pentagons. The point that I made at the bottom of this slide, the MMSE, the mini mental state, does not test what we call executive brain functions. That is higher level functions involving frontal lobe, judgment, insight, abstract thinking. Those are very much cognitive functions that are involved in capacity, particularly of complex decisions like making a will. And this is a limitation of the mini mental state. The one that was referred to earlier, and somebody asked about the Montreal assessment, it's called the Montreal Cognitive Assessment, or the MoCA. It was developed in Montreal by some neurologists primarily, and it's similar to the MSE, but it's more sensitive. So it involves 5-word recall instead of 3-word recall. It involves the clock drawing test, a very commonly used screening test, and it does test executive brain functions. Again, we're limited in time, but there are specific tests that can determine whether somebody's executive functioning is impaired. They usually involve set shifting, mental set shifting. You know, it's been said that the damaged brain is a sticky brain. They can't really, it's not nimble. It can't shift from one mental set to another. So we have developed tests that actually test their ability to shift mental set. And that's one of the features of the MoCA. Particularly the clock drawing test is involved, which is different than the MMSE. But let me just say this about cognitive screening tests. They are not diagnostic. You can't make a diagnosis of dementia simply from a cognitive score. You can tell somebody's impaired or not. You can tell they may need further investigation, but it is not diagnostic. And it certainly doesn't tell you whether somebody's capable or not. You can be impaired on the cognitive scores and still be capable. Conversely, you can have a fairly high score and be incapable depending on the specific circumstances. So that's why it's complicated. And that's where I think medical experts may have a role in collaborating with lawyers, collaborating with the courts, and helping the courts make the best determination possible. So I think that's probably adequate as long as we have a little time for questions.
Yeah, so if people have questions, they can put it in the chat. But right now, we're waiting for some. But tell us about, should I as a lawyer be doing one of these tests on my clients?
Okay, good point. And, you know, I'm a firm believer in the old adage, cobbler, ply thy trade. And I don't think medical experts should pretend that they are legal experts and know the law and case law. And I think it's probably best that lawyers don't try to do cognitive screening tests. There are issues in the administration of the test. There are issues in the administration of the test. And I think if you're concerned about somebody's cognitive functioning, then at the very least, get an opinion from the family doctor if they've done a screening test, if they have evidence on the records of a cognitive screening test being done, that a family doctor can interpret for you. And certainly as a medical expert doing an assessment, that is something that the medical expert should be able to do for the lawyer requesting the opinion. Here you see some examples of mild impairment. I don't want to go into too much detail in the middle.
I just thought it would be entertaining for you to identify. So one of the tests is that you have to draw a clock face. Well, maybe you take us through what the test is.
Well, the test, it's a simple test, and originally clocked, there's the instruction. I use a pre-drawn circle. Here's the instruction. This is a clock face. Fill in the numbers. That's the first part, and then set the time to 10 past 11. So that's the instruction. The reason that this turns out, clock drawing was originally thought to be a test only of visual spatial ability, which involves a very specific area of the brain, the parietal lobes. But in fact, it turns out to be involving much broader range of cognitive functions. And that's why it's a good screening test, because a good screening test basically wants to test a broad range of functions so you can pick up a signal that there is impairment somewhere. And then you can probe that further. So the main purpose of a cognitive screening test is A, pick up a signal, is there impairment? And the other important part of a cognitive screening test is that over time, and here's an example of clocks that deteriorated over time, it is sensitive to change over time, and therefore it is useful to tell you whether somebody is pursuing the course of a dementia. And therefore, in retrospect, when they got suspicious about their daughter-in-law, was this most likely a delusion in the early stages of dementia? So you can see her clocks deteriorating every 6 months in people who already have dementia. So hopefully that clarifies the role of cognitive screening.
Thank you. So the last thing that I want to just do, and we do have a couple of questions, is the idea of aphasia, and first of all, what is it, and how does it impact on cognition, and
Okay,
how
so
you
very
deal with that?
important question. Aphasia is a communication deficit, often associated with stroke, or can be head injury or any other type of neurological insult. And from a medical expert point of view, from a capacity point of view, when somebody has aphasia, a communication deficit, it's very important to try to differentiate the underlying cognition from the communication deficit. And so there are methods, particularly developed by speech and language pathologists, but that I've learned as well, that you can find ways to establish a line of communication using using symbols, yes, no, various combinations to ensure that the person is A, understanding what you're asking, and B, communicating what they want to communicate. It would be problematic if you didn't separate out a communication deficit from their underlying understanding and appreciation of the issue. So yes, that is a specific challenge that needs to be addressed often, particularly in the case of a history of stroke.
Is there something that you would say, based on your experience, that, if a lawyer heard this, go get an assessment? What would you say if you had to list a few items, if there is such a thing, that you could say, like, these are things that would concern me about cognition and capacity?
You mean from the lawyer's point of view?
Yeah, just things that a client might say that might give indications that, this person has that.
Well, first of all, if you're having difficulty with the client's understanding of what you're trying to do, or you start to become suspicious that they're not remembering, you can form your own opinion. If there is an unusual distribution where they're cutting out a child, you need to be able to probe that. If they're not able to give you clear instructions or rationale, that's an important issue. If they express accusations of suspiciousness and paranoia, that is a suspicious circumstance. If it's a significant departure from a previous will, that is a very important issue, of course. That raises the threshold to me. If somebody comes to you and now they're making a will that's radically different than one that they made just recently or not that long ago, those are the kind of red flags that you need to look at. The other red flag is simply age, great age. The epidemiology of dementia is much higher in the very old. So you have to be a lot more suspicious of an 85, 90-year-old than you would of a 70-year-old, for example. I see that Jordy is very familiar with my slides. You can whip up anything that I'm talking about instantaneously. But this slide basically shows that the yellow, the over 85s are growing at the most rapid rate, and they have the highest rate of dementia by far. So great age, change of a will, departure, something unusual, suddenly cutting somebody out, expressing suspiciousness. Those are the sort of things. Sometimes, clients, testators will be reluctant to have an assessment, but I think they have to understand that contemporaneous assessment, especially where there's a likelihood of a challenge, will be a great protection from a future challenge if you can get one done properly.
What about forgetfulness? You know, you're having a meeting, they've said, I want to do this, and you're talking, you come back to it again, and oh yeah, what did I say about that? What
Yeah.
is that like? How concerned should we be about that? And that's
Well, I
sort of
think forgetfulness
final
is a
question.
concern, but let me just say this: forgetfulness alone is not a reason to consider somebody incapable. There's nothing wrong with prompting somebody who is forgetful. There are a lot of people with early dementia who have difficulty with short-term memory. They can't recall what they did. But if they're prompted and they're given an opportunity to explain their rationale, their understanding of their estate, of the people around them, then I think they could potentially be capable, even though they are forgetful. The delusion idea is much more problematic because that's often fixed. But forgetfulness should be a red flag. Um, if somebody has a diagnosis of Alzheimer's disease already established or stroke, that should be a red flag. But in and of itself, it doesn't mean that they're not capable. And a little bit of prompting, there's nothing wrong with a little bit of prompting. I don't think that capacity means you have to be able to do everything spontaneously without any help. Um, we now are much more sympathetic to the concept of supported decision making to help vulnerable people, compromised people to make their own decisions, as long as with a little bit of structure, they can pull the facts together and create a coherent and rational explanation for their wishes.
Well, Dr. Shulman, thank you so much. This has been so interesting, and you know, it's something we deal with all the time, and to have your expertise on it from a medical point of view is wonderful. I thank you so much on behalf of all of the participants for your time.
Thank
And
you. Thank you. I wish we had more time, half an hour. I just get warmed up in half an hour. So, that's a
maybe
problem.
we'll have part two. What do you say?
Anyway, I welcome opportunities to interact with lawyers. And as I said, this is a medical legal collaboration. It's one that invites lawyers and doctors to talk to each other, and lawyers to explain to doctors what they need to know for the purpose of the court. So anyway, thank you, Jordy, as always.
Thank you. And thanks to all of our participants. And hope you found that useful. And we'll see you again next Thursday. Have a good week, everyone.
All right.